family, vacationing, boating, and listening to music. In the last year, he has found a new pastime and faithfully rides his Peloton. His favorite instructors are Dennis, Alex, and Leanne. And after he finishes his Peloton workouts, he enjoys opening up a bottle of Italian wine, preferably a Barolo or an Amarone, and sharing it with his wife and planning their next travel adventures. So welcome, Dr. Garcia. I'm going to hand over the Spotlight series to you, and you can take it away.
Thank you, Deb, and thank you for the honor to speak to all of you. I hope you find this educational, and most important, if you have any questions or any issues, feel free to give us a call, and some of the office information will be at the end. So when we talk about interventional radiology, what I first want to point out are there's a multitude of things that we do. My practice particularly is really with vascular disease and some tumor, both benign and malignant treatments. And so from the vascular disease standpoint, we not only evaluate and management peripheral arterial disease, but also carotids and AAA, mesenteric ischemia, for example. On the venous side, we evaluate and manage acute and chronic DVT, pulmonary embolism, varicose veins or insufficiency, and wound care. We also do a number of women's and men's health treatments, which include fibroid embolization or pelvic congestion treatments, in addition to prostate embolization and varicocele embolization. And then on the interventional oncology side, we do chemoembolization, radioembolization, and a number of ablation treatments, for example, for renal or liver disease, which include cryoablation, radiofrequency, or microwave. So here's just a composite sketch of what IR can do with arterial venous oncology, women's health. The others, of course, not that we do it in our practice, but in St. Francis would be treatments such as drainage and biopsies. So we all have been affected by COVID-19 in many ways, but what I really want to highlight today is what the effect has been on the vascular bed. And I think this article really, which is a meta-analysis of 42 studies, really sums it all up. In over 8,000 patients, what was found is that the involvement of the vascular system contributes significantly to morbidity and mortality in this population. Early reports linked coagulopathy and thromboembolism to show that there was an increased risk of death in patients who developed these issues during COVID. What we saw is that there were abnormally high levels of pro-inflammatory cytokines in the COVID population, which resulted in increased systemic inflammation, coupled with endothelial injury that was triggered by the attachment of the virus to the receptor of the cells within the vessel, and that this led to a prothrombotic endothelial dysfunction. What we also see is that platelet activation, in addition to immobilization, particularly in the ICU with mechanically ventilated patients, and the use of central venous catheters, were significant factors that contributed to this prothrombotic state in the COVID-19 patient. A recent study that looked at autopsies found that almost no organ in the body was spared of thrombosis. And regardless of the anticoagulation status, significant micro and macrovascular thrombosis was found in multiple organs. People ask, oftentimes, how come young people were having cardiac issues, for example? Well, it's not coronary artery disease, so to speak, as we see in the elderly population. It was actually the microvasculature within the musculature which was causing a lot of these issues. And this same thing is found in the pulmonary and hepatic beds, as well as in the extremities. And so all this increase in both arterial and venous thrombosis clearly led to a higher mortality rate. And when you look at the data, which is quite startling, in COVID patients, the venous thromboembolic events went up 21%, and in the ICU population, it was seen in 31% of the population. DVT specific was seen in 20% of the non-ICU and 28% of the ICU population. In the postmortem patient population, it was seen in 35%. For pulmonary embolism, same thing. Non-ICU patients, 13% increase, 19% in the ICU, and in the postmortem population, PE was seen in 22%. Arterial thrombosis, not quite as high, but significantly higher than the normal population, saw a 2% increase, and the ICU population a 5% increase. What this really all led to was a pooled mortality increase in COVID patients of 23% in those with thromboembolic disease versus only 13% when they did not have a thromboembolic phenomenon. And the pooled odds of mortality went up 74% in patients with thromboembolic phenomenon for a significant p-value. Now, throw this on top of the non-pandemic rates of peripheral arterial disease. You can see here that in the U.S. there's over 12 million patients with peripheral arterial disease, half of which are asymptomatic. But of the symptomatic population, it's clearly that it's an underserved population. Only 25% of symptomatic patients actually get treated, whereas 75% are untreated. When you look at amputation rates by the region, and this is all Medicare data, in the amputation rates in 10,000 Medicare patient population, the rate is the highest in the country, in the category, I mean now, in the upper Delaware region. So it's really obviously an underserved and underevaluated population rate. It's hard to believe that in upper Delaware that you would see the highest rate of amputations that's been categorized by CMS. So when we talk about chronic limb ischemia, what's the significance of this? Well, life expectancy is reduced 10 years in a patient with normal peripheral arterial disease. When you look at the mortality rate and compare someone with claudication versus someone with chronic limb ischemia, you see at 5 years there's a 25% mortality, but in somebody with CLI, it's 55%. And at 10 years, it's 50% mortality with claudication that goes up to 85% at 10 years. In general, 75% of deaths in the population of PAD patients is caused by some degree of cardiovascular event. So the goals of evaluating and treating chronic limb ischemia is to reduce these major cardiovascular events and premature death. This includes smoking cessation, weight loss, diabetes control, getting patients on antiplatelet and statins, as well as ACE inhibitors and ARBs, and a referral to appropriate specialist. We also want to obviously have limb salvage, and that is to revascularize the arterial bed, provide wound care and infection control, and hopefully improve the patient's activity and quality of life. The most effective and clinical impact on this patient population is when you have a team approach for a heart and vascular team, which is what we're aiming to do here at St. Francis by developing the Heart and Vascular program. Myself, obviously, as an interventionalist, is only one little spoke in the wheel, but it's going to have to involve many subspecialties to really get this clinical impact to the community. Now, if you ask why would you treat and what's the cost of chronic limb ischemia? Well, there are about 2 million patients with chronic limb ischemia in the U.S. 25% of these will require an amputation within 1 year of diagnosis. 50% have a 5-year mortality rate post-amputation. The financial cost of an amputation is estimated to be $10.6 billion a year. And this does not include the direct patient cost or societal costs with lost productivity. Sadly, evaluation is underutilized. When you look at patients who undergo a major amputation in the U.S., in the 2 years prior to the amputation, 24% did not even have a diagnostic vascular study. 69% had no attempt at revascularization whatsoever, and over 90% did not even have an angiogram to consider revascularization. 46% of this population ended up getting an above-knee amputation, which is a significant decrease in quality of life and ability to be productive when you look at an above-knee versus a below-knee amputation. There are lots of advancements in the treatment of chronic limb ischemia. The goal here is to revascularize in an unobstructed single vessel to the foot. You want direct inline flow. And there's tailored reperfusion evidenced by the angiosomes, which you see on the pictures here. Angiosome-directed revascularization is shown to improve wound healing rates and improve limb salvage rates. So here's an African-American female who clearly has very severe disease with gangrene and ulcers. As you look at this, you say, oh my God, how frightening this could be. So if you look at the antegrade angiogram, you see that there's a diseased posterior tibial artery, but an occluded anterior tibial artery which feeds the dorsum of the foot. you can get selectively with a catheter all the way down into the foot. And actually the plantar artery communicates to the dorsal side of the artery or the dorsal artery, and it's called the pedal loop. And we can get around that pedal loop, which is evidenced here by the wire coming down around the pedal loop, and you can do balloon angioplasty across this pedal loop. This may allow for access directly into the foot with a microcatheter system, which then allows you to get up retrograde the leg and do balloon venoplasty, seen here with the balloon across the anterior tibial artery. And in the end, you now have 2 vessel runoff to the foot and a significant improved perfusion to the pedal loop and to the foot. Now, that person's foot was pretty much dead when we got to there, but what they ended up having is an amputation which saves the lower leg and ankle. This person can actually be fitted for a shoe and ambulate without having to worry about a leg prosthesis. And this is it healed within a couple months. Here's actually a patient hot off the press from yesterday who is a female with diabetes and has peripheral arterial disease status post amputation of multiple toes bilaterally. And you can see here that there's this chronic non-healing ulcer of the left lateral foot. Here's the initial angiogram, catheters down here to the just below the knee, and here's a single vessel runoff via what's called the perineal artery. But both the anterior tibial as well as the posterior tibial arteries are occluded. And when you look down the leg, this vessel becomes, the one single vessel becomes very diseased and has very poor flow beyond the level of the ankle itself. So there's no wonder why this person had amputations and a non-healing ulcer. And here you can see with the circle that there's essentially no perfusion into the foot on this oblique image. Here we are. We were actually able to come down and recanalize that chronically occluded posterior tibial through the plantar artery, and we get a loop, we get a wire all the way around the loop into the perineal artery. And this allows us to do our intervention where we do a loop angioplasty from the one side to the other side of the foot, all the way back up the leg, and between atherectomy and balloon angioplasty, we're able to now create this vessel that was previously occluded, improve the vessel that was already there into the foot, and now you can see that there are vessels that are crossing the ankle joint into the foot, providing that pedal loop, and should allow this person to get healed up. And this is just a comparison from the pre and the post, as you can see the improvement, particularly in the lower leg and foot. Now, as I mentioned, one of the other complications of COVID is venous disease. And I think we've worked very, very hard at changing the landscape of DVT and pulmonary embolism over many years leading up to the COVID situation. So just as a background, as we mentioned, PAD affects about 12 million patients in the US. Well, chronic venous disease, which includes DVT as well as venous insufficiency, actually affects over 80 million people. When you look at VTE or venous thromboembolism, which includes DVT and pulmonary embolism, there's nearly 1 million patients a year that present with some degree of venous thromboembolism. This is about a 33% increase that was seen from 2002 to 2006, and it's actually projected to double by the year 2050. Females are more common than males, and it's 6 times more common in the elderly population. When we talk about venous disease and the pathophysiology, whether we're talking about obstructive post-thrombotic sort of DVT situation, or we talk about reflux in the venous system due to bad valves, it all creates what's called venous damage and venous hypertension, which leads to the venous permeability and the sequelae what we see on the leg. And this is, again, all done by venous hypertension. That's really the culprit. When we talk about DVT, there are 2 basic types. That's acute DVT and chronic DVT. And in simple terms, it's really soft clot or hard clot. And depending on what it is, sort of determines what kind of treatment they'll get. When we look at the acute DVT population, what we really want is to let these people declare themselves as to whether they're going to develop post-thrombotic syndrome. Some patients may not need anything but anticoagulation, and they'll actually autolyse their own clot. And so what we want to do is we want to follow these patients with ultrasound and physical exams up to 3 weeks, making sure that they have therapeutic anticoagulation, compression socks, and increased activity with walking, using that calf pump to help recanalize the vessels. If there's clinical improvement, both clinically and ultrasound improvement, then we'll just continue to observe them. However, if they're looking like they're developing post-thrombotic syndrome and have no improvement, those are the people we want to treat by 4 weeks. And the reason we want to treat by 4 weeks is because that clot is still soft, and very typically we can do what's called a single session thrombectomy, get rid of the clot and get the patient back home either the same day or maybe with an overnight stay. When we talk about chronic DVT, this is much harder clot. And so the chronic DVT, we want to do what's called ABCs of DVT. And they include A is activity, B is for blood thinner, and C is for compression, similar to the acute population. We're going to follow this with ultrasounds and physical exams. If there's no or minimal post-thrombotic syndrome, we stay with the standard of care, which is the ABCs. However, if there is significant post-thrombotic syndrome affecting the quality of life and activity level, then we would proceed with a study that was performed and published called Access PTS, which is the chronic DVT treatment. So the recommendations for treatment would be if someone develops phlegmasia from their DVT, we really don't wait on this population. We do pharmacomechanical single session thrombectomy to clean out the clot. If someone has an IVC or iliofemoral DVT, so it's a very central clot, you again want to perform pharmacomechanical thrombectomy because this population has a very significant high risk for developing post-thrombotic syndrome. For people who have infrainguinal disease, it really depends on whether they're symptomatic or asymptomatic. And for symptomatic patients, you really want to allow them again to show that they're not going to have any improvement, and therefore you may consider pharmacomechanical thrombectomy in someone who doesn't show any improvement. But if they're showing improvement, you really just need to continue to evaluate. And overall, every patient should be determined to have a risk-benefit ratio to make sure you do no harm. Here's an example of a 55-year-old obese female who had a history of DVT and actually had an IVC filter placed many years ago. She was having TIAs and had undergone incisional hernia repair and developed post-op large abdominal hematoma with post-evacuation. Following her surgery, she developed IVC and bilateral lower extremity DVT with severe swelling and phlegmasia. This person would be a very high risk for the old standard catheter-directed lytic therapy. And on this initial venogram coming from the knee, she has an occlusion in her popliteal vein. There's some collateral flow going through the saphenous vein, but it also occludes up in the upper thigh, and everything central here is completely occluded. So we did what's called rapid lysis. We did a single session thrombectomy, and over 48 minutes, we're able to suck out all this fresh clot and restore direct inline flow all the way back through the filter and heart. We came back 4 days later and treated the other side, the right leg, and she had a significant reduction at that time in the pain and swelling on her left leg. And here's her right leg, and here's the significant clot burden in the upper thigh with complete obstruction in the pelvis. And again, within minutes, we're able to clean this out, and this person did extremely well and was clot-free for many years until lost in follow-up. Here's a little bit more of a drastic case with portal vein thrombosis in a 67-year-old female who had a history of hypertension, and she was presented to the hospital and admitted with abdominal pain. Her admission CT showed splenic infarction with arterial and venous thrombosis, and including the portal vein, and she was put on anticoagulation with worsening pain, and she propagated her clot to involve the entire portal vein. Actually, she was given last rites in the hospital, and we were asked to see if we could do some life-saving procedure. This was her initial CT scan, which showed this low density here in the portal vein, and there was contrast here, so it wasn't thrombosed at that time. However, the splenic vein was thrombosed, and this low density area you can see is the infarcting spleen. She was clinically worsening, and her follow-up 1 week later showed the clot now extended all the way into the portal vein, and now you can see the very low density infarcted spleen. And here's some clot in the portal venous system again. So this person was really going the wrong way. So we intervened by coming from the side of the belly through the liver into the portal vein. And here's our venogram showing lots of clot in the portal venous system all the way through the the splenic vein. The SMV was actually open, but was flowing nowhere. And here we're going to see coming up. This is after doing a thrombectomy and thrombolysis. We can see we restored flow all the way through the liver, and you can see the blush of the liver tissue. This woman did extremely well and is actually discharged a week later. So concerning chronic DVT, this is an area that I've had a lot of success and have really enjoyed making a difference. There's millions of patients who suffer from post-thrombotic syndrome. And for many of these patients, anticoagulation and compression is not enough. And in medicine, we've been taught for many decades, if not a century, that nothing can be done with chronic DVT. The patients have to live with it. And they're still being taught this all over the world, that you just have to learn to live with it. There's 600,000 venous stasis ulcers every year at a cost of $3 billion. And as I said, medical management is often not sufficient. So when patients develop symptoms that persist with quality of life suffering, we should consider intervention. The severity of the post-thrombotic syndrome is directly proportional to the degree of what's called ambulatory venous pressures. The higher the pressure in the leg, the more severe the post-thrombotic syndrome. The goal of intervening here is to relieve the obstruction, restore flow, and thus decrease those venous pressures and subsequently the severity of post-thrombotic syndrome. Here's a 12-year-old clot in a woman who came in who actually had a hysterectomy that became complicated, and they actually clipped the iliac vein. She woke up from anesthesia with severe pain, and she lived with this for 12 years with conservative management. This was her initial venogram. She's got popliteal vein disease. She occludes at the femoral vein, and she's decompressing what's called axialization of the femoral vein through the profunda, but then again occludes at the hip. And this right here is the clip that was inadvertently placed many years prior. I was able to nudge up into that clip and serial dilate with a balloon and open it up. And using our Access PTS ultrasound accelerated thrombolysis overnight, we were able to open up the vein with actually reasonably good flow and stent across that previously occluded clipped iliac vein, and she was able to decompress completely. Over 5 years, she was extremely happy. She became very active with treadmill and cycling with rare and minimal swelling. She had no residual pain, and this was a woman that couldn't stand for 5 minutes at her stove to cook prior to the treatment. So what is the data on chronic DVT and PTS? And the question, can chronic venous occlusion really be recanalized? And the answer is absolutely yes. This is the trial and the results that I published from a multi-center study back in February of last year in the Journal of American Heart Association. When you look at all metrics that were evaluated, whether it was Volata or VCSS, which are two measures of the degree of post-thrombotic syndrome, or whether you look at quality of life via what's called SF36 or the veins quality of life, those are quality of life measures, there was statistically significant improvement in all measures that were used. When you look at Doppler patency out 1 year, there's mid to upper 90% patency in the previously occluded venous systems. So Access PTS was statistically significant. 67% of the population reached the primary endpoint. And as I mentioned, Volata, VCSS, veins, and quality of life SF36 scores were all statistically significant with excellent Doppler patency rates. Here's an example of a 13-year-old chronic DVT in a woman, 60-year-old female who had pelvic chondrosarcoma in 1996. She had a hemipelvectomy with radiation treatments, and in 1999 developed extensive DVT. She was placed on anticoagulation and compression for 13 years and was actually quite miserable. Here's an X-ray, and you can see her right side of her pelvis is gone, completely gone. Her hip has been migrated upwards. This is an MRI showing the edema and the enlargement of her leg compared to the opposite side. And this was quite challenging getting into the little tiny popliteal vein that basically occluded and showed all these wispy little collaterals in the thigh, but nothing centrally across the pelvis. And here we are after gaining access across these occlusions. dilating them and using the ECOS, you can see that we've restored flow back through the IVC with a tremendous improvement. On discharge, she was placed on enoxaparin. She had her elastic compression socks, and through 12 months of her office visit, her pain had resolved actually within a month. Her skin softened up. She had some decreased hyperpigmentation and swelling, and she was actually out of a wheelchair ambulating. Despite that hip, she was able to ambulate and have a much better quality of life until ultimately she passed. This was her follow-up ultrasound at 12 months, and these veins were previously occluded, and they're now open with color flow that we're seeing, which is actually relatively very remarkable. So in conclusion of the chronic DVT, again, I would implore you to read Access PTS and look for the statistically significant improvement, and to let patients know that there is hope is here for those who have failed the standard of care. Now, aside from chronic venous disease, there's another part of this, which is the non-thrombotic. And these patients that you're going to see pictures of all have swelling, hyperpigmentation, skin thickening with a negative venous Doppler. And this is a very, very common presentation to our office in patients who have had these symptoms, signs and symptoms for many, many years. And because they had a negative Doppler, people just sort of assumed that there was really nothing wrong. But you need to think about iliac vein compression syndrome. So here are these patients. You can see the darkening of this skin compared to the opposite side. Here's the hyperpigmentation with an ulcer, skin fibrosis, another one with severe skin changes and an ulcer here that was non-healing for almost a year. Here's another man with, again, hyperpigmentation, some redness, very thick fibrotic skin. This person, who was found to have severe iliac occlusive disease, underwent stenting, and in 3 months, this healed up finally, which was a very, very painful ulcer and was keeping them from working. So what value are we providing? I think it's an opportunity for us to alter the course of chronic venous disease. Treatment leads to reduced progression of chronic venous disease, reduced ulcers, reduced hospitalizations, and lost work days, and the ability, most importantly, to significantly improve a patient's quality of life. So in conclusion of the DVT management, acute DVT can safely and effectively remove thrombus and relieve symptoms and potentially reduce post-thrombotic syndrome. And for chronic DVT patients suffering from post-thrombotic syndrome, we are able to recanalize these patients' disease and improve quality of life. So on to a little bit of oncology. There are several different tumor types that we manage in IR: bone, renal, liver, and lung. And there are a multitude of different types of treatment depending on the location and the type of cancer that it is. Okay, so the types of intervention, again, chemoembolization, which is where we inject particles to basically stop the blood flow to a tumor. Sometimes they are particles that are coated with a chemoembolic drug, a chemo drug, or it may be something that's coated with radiation called yttrium-90. And then again, you can do ablation therapies if appropriate. This is just a depiction of where the catheter goes in to the blood vessels feeding the tumor, and we inject these tiny little particles that may or may not be coated with chemoembolization, or excuse me, chemo drugs or yttrium to get the effect. Here's an example of a hepatocellular carcinoma in a 64-year-old male who had a prior alcohol abuse, 13-centimeter cancer, who by all standards would have had a length of life of about 6 months from the diagnosis of this HCC. We did 3 treatments. This is a CT scan that shows the pre-treatment of the hepatocellular carcinoma, barely visible on a SPECT scan. And here is the angiogram showing the vascularity to the vessel, and we did chemoembolization. And here's actually the chemo drug with what's called lapiodol. It's an oil that very clearly shows the mass here. And this mass remained stable at 12 by 10 centimeters for 7 years. This man lived before he actually succumbed to other medical problems. Here's a woman, a colorectal Mets, 51-year-old. She was actually a friend, a cytotechnologist at Christiana, who was found to have metastatic colorectal carcinoma with diffuse widespread disease. You can see on the liver all these little low density lesions. It looks like Swiss cheese. She was just rampant with disease in her liver. We treated her in April of 2004 with yttrium. This was a 5-year follow-up. She does have a cirrhotic liver, but she's alive, doing well without any recurrence of her disease and no signs of cirrhosis. And lastly, we're going to talk about women's health and focus on uterine fibroid disease. This is the most common pelvic tumor in women. Hysterectomy is the second most common surgery performed. Fibroids are the #1 cause for hysterectomy, with the average age of a 39-year-old female. Many women are actually not given the alternative treatments for this disease. Just for your pleasure, this is what the gynecologist sees. Looks like a gremlin or some goblin. This is what we see. We get in with a catheter into the uterine vessels, we inject, and they're extremely hypervascular with lots of blood flow to the large fibroid uterus. As I mentioned, these are hypervascular tumors, which actually allow for an embolization procedure to be extremely effective. There's a very short recovery. Half the women are back to work at a week and half at 2 weeks. They're able to maintain their fertility and go on to have children. And MRI is really what we need before we do this procedure to determine if they're a good candidate for fibroid embolization. Again, a little depiction of a catheter going into the blood vessels that feed the fibroid, where we'll inject these particles, tiny grains of sand, which will go in and block off the blood vessels and starve the tumor from oxygen and blood nutrients and infarct it, and it dies and shrinks down. Here's a pre-embolization angiogram showing the diffuse nature of the vascularity. And here's after we shut down all the blood flow and no more fibroid blush on the uterus. In the appropriately selected patients, UFE is 90 to 95% successful. It significantly reduces or resolves the heavy menses that they have and eliminates the bulk symptoms, which can include urinary frequency, pelvic pain, dyspareunia, low back pain, and constipation. I know that was a lot to go through. I'm willing to take any questions. This is just EndoVascular Consultants, how you can get a hold of us, and feel free to let us know if we can help you. Thank you.
Great job, Dr. Garcia. That was an amazing presentation. Lots of content, and really like the images, because it just definitely shows, the work that you're doing and how significant it is to patients' lives. So very nice presentation. Does anyone have any questions for Dr. Garcia? Dr. Cosgrove, do you have any questions?
Yes, actually I do. Hi, Mark. Great presentation. My question is, we quote patients when we do an abdominal myomectomy as the chance of them having not only return of their fibroids, but actually a 40% chance of a second operation. So we generally quote that the chances of them having fibroids return in their lifetime, especially in the younger 30, 40-year-olds, is 40 to 50%. When you do an embolization, what do you quote as the chance of the recannulization or the formation of additional fibroids that will require intervention?
Thanks for that question, Jim. It's great to see you, and I'm a little mad that I didn't see you before you decided to leave. Congratulations on the new job, by the way.
Thank you. I'll be there next week.
Okay, you better stop it.
So I'll stop up and see.
Yeah, our loss, their gain, as I said. Okay, so what we quote patients, and if you look at the registry that was done, the actual recurrence rate of a fibroid, and there's a debate as to whether this is actually a progression or new fibroids, because they obviously have a fibroid disease uterus. We treat the whole uterus, and so when you look at the data, it's between it's between 10 and 14% over 7 years that there is a recurrence of fibroid disease from the registry. And that's what we usually quote them.
And is fibroid disease mean it's symptomatic disease or just the return of fibroids?
Yeah, normally that's a return of fibroids. The symptomatic return is probably about 7%. Now, there are some people that fail the procedure. It's not an all-come. Most of the failures that I've seen, though, have actually been because There was so much fibroid disease that we got huge infarctions, which caused prolonged periods. That's not common. That's a very small, low single-digit number that had to leave to further surgical intervention. But on the vast majority, again, that's where the MRI really is very, very helpful. You can also do it in a staged procedure so that it's not overwhelmingly infarcted all at once.
Good. Well, we've had great success with you doing embolizations for our group, and we appreciate it. And I hope I can speak to the people it fits and continue a relationship with our interventional radiologist to continue this therapy. Thank you.
Yeah.
Any other questions for Dr. Garcia? So there is one question. How do I differentiate arterial and venous disease?
So in general, if you think about it this way, arterial disease is inflow, taking oxygen and nutrients into the leg to survive. Venous disease is like, so it's like the water main basically coming into your house. Venous disease is very similar to the septic system. And so if you think about it, when you have a problem in the water main coming in the house, your house gets no water. It dries up, plants die, etc. Well, that's where the leg actually becomes it can become gangrenous. It starts with claudication symptoms, which are basically very reproducible. Someone walks, they get pain. Someone stops, it goes away. They start to walk, it comes back. They stop, it goes away. That can progress to ischemic changes such as gangrene and loss or dead tissue. Venous disease is actually quite opposite. Because it's like the septic system, when the septic system backs up, you get water overflowing, you get that in the leg is swelling. So as the blockage or venous hypertension, as I mentioned earlier, gets worse, then what happens is that permeability in the vein wall opens up and water starts to seep out, giving you edema. And then over time, your body and the immune system starts to combat that, and you start to see hyperpigmentation, which is actually iron content from the blood seeping out and staining the skin. That's the hyperpigmentation. Fibrosis is from the immune system trying to combat that because it's not normal, and it causes that leathery skin change that you can often see. So hyperpigmentation, swelling, oftentimes is venous disease, whereas claudication, cold, painful leg is more of arterial disease.
Okay. What would be the initial workup for arterial disease, and what would be the workup for venous disease?
So the initial, if someone suspects that there's an arterial problem, a physical exam is obviously the first thing. Do the feet feel cold or foot feel cold? Is the skin shiny versus leathery, which is venous? But if it's shiny and hairless, that often says that there's an arterial problem. And the next thing would be just checking pulses. And if the pulses are decreased, then I would get an arterial Doppler study with an ankle brachial index, and that gives us a very high suspicion as to whether there's a problem. The only caveat to this is if somebody has diabetes, they have calcified arteries, and the ABI will be falsely abnormal or falsely high. So if you get an ABI that's like 1.2 or 1.5, that's abnormally high. And so you have to suspect that there still may be disease. And in the venous side, again, you would start with a venous Doppler study, a venous insufficiency study to look at valvular reflux going down the leg. And if those pictures, if you remember, if your patient looks like that and they do not have any DVT or venous insufficiency, then a CT venography is usually what I'll order to look at those veins to make sure they're not narrowed and compressed, which oftentimes they are.
All right, any other questions? Oh, go ahead, Debbie.
I have one that just came through. So thank you, Dr. Garcia. When should we refer patients to you? So basically we have patients that are coming through. When should they start referring to you? When they're suspecting that there's issues going on?
Yeah, so I mean, I think the first thing probably would be just to give a call and see if it's appropriate. You know, we can kind of decide and discern what the issues may be. But again, you know, when you suspect that somebody has arterial disease, as I mentioned, the workup, I think that's a basic thing that we can do that would help to make that diagnosis. And if they are clearly reproducible and the signs and symptoms are there, then I would highly recommend just going ahead and referring to us. Same thing on the venous side. I mean, I think there's things that you can do initially, but look, the bottom line is if you're not sure, you're confused, you really don't know, we're more than happy. I have a new partner that's helped to decompress, and Dr. Sonia Turfs, who some of you may know, is a vascular surgeon. We're all actually merging our practice together, so we'll be able to provide evaluation and management of a wider range of vascular diseases. So if you have questions, just pick up a phone call and just ask the question, and we'll be able to help direct you.
Okay, thank you. And what I'll do, Dr. Garcia, is I'll put together a quick reference guide for the practices and distribute it out so they have the number, so they can go ahead and call if they should have any questions.
Right.
And I'll make sure that it goes to the front desk, and then they can go ahead and schedule some time if the doctors do need to speak with you.
Okay, great. Thank you.
All right, any other questions? All right, Kathy, do you have the number for the to retrieve the CME credits again?
Yes. Let me see. I can definitely get that. Hold on one second. Sorry, I didn't pull up the.
So for everyone on the line, there's one CME credit for this presentation. There is a link in the WebEx invite or the Teams invite that we sent. You can go to that link, you use your name, and then the number that Kathy's going to give us in a second. You have 30 days to go in and retrieve those CME credits, so make sure you do that. You don't want to miss out on that opportunity. And Kathy, you there yet?
Yep.
should talk slower.
Yes. 1 second. It's pulling up his presentation. I'm so sorry. Go look other places too. Let me see.
Is it the number at the end? Event number?
Yes, doctor.
Yeah.
It's 44439.
Thank you.
You're welcome.
All right. So if everybody jots that down, 44439, make sure you go in and get those credits. And thank you again, Dr. Garcia. Excellent presentation. Great work for our patients. And hopefully everybody will enjoy the sessions that we have upcoming in the next couple of weeks. Have a great weekend.
Thank you.
Thank you.
Bye.
Thank you, doctor.
Thank
Bye-bye.
you, everybody.
Deborah.
Dr. Garcia.